Welcome back. If you're joining us, you're watching Channel 1 News Hour. We now shift gears and focus on our interactive segment, Your Health. Of course, we get to talk about what everyone is talking about, affordable healthcare, and we will be biased towards universal healthcare, and particularly how is it that we change our lifestyle as Kenyans? How is it that we change how we think to try and move towards preventive treatment rather than curative treatment? And for more insights, joining me in studio this evening, on my immediate left is Dr. Musuva, who is the Chief Operations Officer at Population Services Kenya. Thank you, Anne, for joining us this evening. Next to her, we have Dr. Simon Kigondo, who is the Secretary General from the Kenya Medical Association. Thank you for joining us this evening.
You're welcome.
All right, let's begin with what everybody is talking about, affordable healthcare, universal health coverage. How does it fit into the current systems that we have, particularly when we talk about devolution?
Perhaps I could start by just defining what universal health coverage or care is all about. So universal health coverage aims to make sure that people have access to preventive, curative and promotive health services without incurring a financial burden. As you know, in our country right now, we always hear of stories of people having to sell all their cows, selling everything that they have, selling plots of land in order to take someone who is sick to hospital, in order to pay a hospital bill. We know of people who are actually retained in health facilities because they are not able to clear the bill. So universal health coverage actually looks at 3 dimensions. So first it looks at what proportion of the population is covered, when it comes to accessing care. It also looks at what services are actually covered. And universal health coverage doesn't mean that all health services are available or will be free for everybody, but we actually have to tailor-make a certain benefit package, which is based on what provides the best return on investment for Kenyans. And that important aspect of us is, of course, is financial coverage, to make sure that people are not incurring financial hardship when they access care.
All right, but even as she talks about everyone accessing healthcare, do people have faith in the public institutions to offer this kind of treatment that, when the government says affordable healthcare, almost, free, do people trust government services when it comes to affordable healthcare?
Thank you very much for having us. Trust is a matter of interaction. If my interaction with you led to a trustworthy relationship, then you will trust the institution. So you will find that there are some places in this country where the populace goes to the public health institution and gets services, and therefore the trust is there. So the aim of any public health institution and the government in general is to ensure that there is improvement in the public health sector. Once you have the public health sector propped up and the public health facilities running very well, then universal health coverage will be possible. Yes.
We're always talking about, reforms in the health sector. Right now we have devolved healthcare, but in terms of the actual reforms, are we seeing it cascade into the ground? Are we seeing a difference in how we offer services?
I think that's a very good and important question. There are certainly some things that we are seeing that are changing when it comes to healthcare. Just for starters, having the government have universal health coverage is one of the 4 pillars of achieving the government's priorities or Vision 2030. It certainly means that increasingly health is being seen as important as a priority. That said, there are many aspects that still need to improve for us to really get to universal health coverage. When you talk about universal health coverage, we've heard of stories of a lot of equipment being bought and it's sitting in health facilities. But really, are the healthcare workers there to be able to use this equipment? We know of MRI machines and CT scans that are gathering dust in health facilities. But do we have, are the healthcare workers there who can actually use these health facilities to benefit Kenyans? So I think when we talk about universal health coverage, we really need to adopt a systems thinking that looks at the entire health system and looks at all the possible issues or challenges that we need to tackle for us to achieve universal health coverage. So not just focusing on one aspect, such as equipment, for example, or infrastructure, but also acknowledging that we also need the human resources and other aspects are important for universal health coverage.
What about the aspect of, the health workers, based on what we've seen, the nurses, the clinical officers? We're always seeing strikes every now and then, and the argument is always that you need to pay us better to offer the services. So are we likely to see a change in that?
Yes, at the core of any health service delivery is the healthcare worker. And the healthcare worker should be treated as a scarce resource. For instance, if we do comparatively, in Britain, they say they have a scarcity of doctors and they have 250,000 doctors. In Kenya,
Depends
we
on the
have,
population.
the population is the same as Kenya's, and they have 250,000 doctors, and they're importing more. In Kenya, we have in the public sector 2,000. And therefore, we, as health workers being a scarce resource, then we would probably be better off with a centralized management of the health workers, which is a health service commission. And that way you can distribute people better, solve their health workers' issues better, as opposed to where they were frozen in a devolution state and you have some governors practicing nepotism, tribalism, and people feel they are not being promoted. Others are promoted above you because they're related to the governor. And then you also...
But is that the situation or that is just a perception?
It is the situation because the natural progression of a doctor, for instance, is that they become medical officers, they work for about 3 years, then they want to go back for specialization, and then after that come back to work. Now in a state like we are in, a devolved state, then the governors say, no, we cannot sponsor you to go to school because we are paying you, and when you leave, that place will be left without anyone. So it becomes, but if you are in a centralized, where you are taken to the national government, then the national government just sends a worker to replace you, they send you back to school, and post you once you are finished to a place of need. That becomes very difficult without a health service commission. And probably to achieve UHC, you definitely will need. There is a bill in parliament by a member of parliament,
Yes.
and we hope this will go through and this will help. That's one of the behavior changes the government needs to adopt. Actually, the biggest person who needs behavior change is the government. Let's see what works and adopt it.
Speaking of, the government and behavior change, today we've seen the Ministry of Health, saying that now they've appointed a 10-member task force to look at NHIF and how it's operated. Do you think it's going to change how, we see operations in public hospitals and access to healthcare through medical insurance?
Well, we certainly hope that this task force will actually lead to some change. But the challenges in the health sector are not just limited to NHIF. And as Dr. was talking about behavior change, for us to actually see a change in the health sector, we need to see changes at all levels, not just at the national government or at NHIF, for example, but even attitudes among healthcare workers themselves, and also amongst the patients or those seeking for care. We need to support individuals and communities in actually demanding for services. Because if we provide all this infrastructure at the health facilities, if the doctors are there and the nurses are there at the healthcare facilities, but the patients actually don't come to demand for those services, then our efforts are really in futility. And this is where social behavior change comes in. And an organization like PS Kenya, where I work, supports the government a lot in social behavior change communication campaigns, in trying to ensure that people can actually demand for the services that the government and other partners have provided.
How do you demand for services when the health workers are not even in the clinics in the first place? Because there's always the argument that they work in their own clinics, they're in government clinics, they're referred every other place. So how do we consolidate this such that the health workers, if you're based in a particular hospital, this is where you're going to serve?
I think for a long time, and this is part of the changes that you need to teach the population. These often repeated things that look true may not necessarily be true. Health needs self-regulation, meaning autonomy. For instance, the measurement of whether a client has been seen is not whether the doctor is working in two places at the same time. Personally, I actually feel that people should work in more places than one, for instance. Why? Because health is an art. The more you do it, the better you become. So what we need to actually measure is for the person, Wanjiko, who goes to a public health institution, for instance, has she been treated? Has she been seen? And when she has not been treated, then you do a root cause analysis and find out what is the problem. More often than not, we assume what the problem is. People will tell you, oh, doctors' fees, the reason debate are high. But then when you ask them, does a patient pay doctors' fees in a public hospital, they'll tell you no. Then you see. So we need actually to change our thinking or our message to the public to actually demand to find out what the actual cause is. So for instance, when people go on industrial strike, they say there are no drugs in the hospital. You see, you blame them, you say, no, they are not in the hospital. But you haven't found out what is the cause. Maybe the government has not provided money to buy facilities, drugs in the hospital. You see, but they may quickly say, maybe those doctors are stealing the drugs or something, you see. But that is not necessarily true. So I think we need to change a lot of things in terms of how we understand the health sector.
And do you agree with him that when they work in many hospitals, they get more experience as opposed to, the argument that they don't, spend the entire time there long enough for you to even see them in the first place? Because the argument is that they're trying to make money in different places.
Yeah. The argument is certainly a departure from the norm. But I think there are two important issues here that are coming up. There have been recommendations, for example, that for health specialists, perhaps they don't need just to be confined to one health facility, and perhaps we should actually, stretch them by making them work in different health facilities, perhaps, on a performance basis or on contract basis. I'm saying this because there are very few health specialists, especially in the rural areas. You might go to an area and find, for example, there's only one obstetrician in a whole county, for example. Would it make more sense for this obstetrician to be based in only one health facility or to move around the different health facilities? So that is one school of thought. But the other thing is that the healthcare workers who are there also must be accountable to their employer.
So because I was going to get to the question of how many hours before you move to the next, because you're supposed to work 8 hours in any organization. So at what point are you moving to the next one, and what does it mean for you physically? Yes.
And this is the problem. When you try to measure the health worker with hours, it's a problem. You are a layman. They usually use the measurements of people who sit in an office 8 to 5 to try to measure the health worker. For instance, currently, I'm on call. I can be called to an emergency in a hospital. So that hour, will you pay for it? You get what I mean? But if I am called, I will go. But is it counted as part of that? You are saying 8 hours. You see, generally,
the reason I introduced that is because I remember the time when the doctors were striking, they wanted to work, I think, was it 40 hours?
Yeah.
Or something like that a week?
Yeah.
Yes.
The reason for that argument is that health workers usually work 24/7 and not compensated for that. So, and because people have taken it for granted that anyway, he's a doctor, he's a calling, and it's not compensated for, you see, then they say, now, you see. And part of, and again, I would like that you need to be left to your supervisor to measure you. For instance, if you have 20 patients to see, and you take the whole day to see them, are you a better doctor than the doctor who came and saw them within 4 hours, let's say? You see, but the argument, and therefore the argument of hours, then you might find a psychiatric patient who you take the whole day to see one patient. So someone will argue that you have only seen one patient. You get the point. So health is a bit more complicated in terms of, as opposed to these 8 to 5.
All right, I don't want to go into the welfare. It's a whole different topic. But I'm informed we're running out of time. But just looking at where we are currently when it comes to universal health care and affordable health, what is it that we need to change in your perspective for us to be able to realize what the government is really keen on implementing?
As I said before, this is, I think, certainly a step in the right direction, the government thinking about universal health coverage. But that said, there are some issues that we need to critically think about as a country. One is, where is the resourcing coming from, to achieve universal health coverage? We know right now that currently about 7% of the government's budget goes to finance health. This is opposed to the 15% that is actually recommended
Yes.
For countries to put into the health sector to achieve a universal health coverage. And so we are still far from where we need to be. So the government certainly needs to put health as a priority and put the resources behind that to achieve universal health coverage. The other thing that I'd also mentioned earlier is that we also need a systems approach. Beyond just looking at, for example, curative health services or looking at small aspects of the health system, we need to think about the entire system. We need to think about human resources, resources for health comprehensively.
Yes.
Do we have adequate numbers of doctors, of nurses? The other thing is that also usually when you talk about universal health coverage, we only focus on the public sector, for example. But you know that about half of Kenyans access their services in the private sector.
Yes.
Organizations such as PS Kenya really focus on the private sector. And I'm not talking about the big hospitals, but the smaller health facilities where many people access care. This also needs to be part of universal health coverage. We also need to think about these facilities. And the last aspect is, of course, social behavior change. Because we can provide all the infrastructure, we can have, the doctors there and the nurses, but unless patients come to demand for the services, unless they know that it's important to be screened for cervical cancer, unless they know that it's important to take their child to a healthcare facility when the child has fever, then we will not achieve universal health coverage. So demand creation is very important, and PS Kenya supports the government a lot in achieving this.
All right. As we wind up, Simon, what she's mentioned, the affordable healthcare, and the general thinking within the Kenyan population that it is cheaper to get treatment in India than in Kenya.
Yeah.
How do we even change that as we wind up?
It is not. But how we change that,
it's cheaper.
it is. How we change that is that universal healthcare will be achieved by a public-driven, public-led, tax-funded universal health coverage. Health workers must be looked for at like a scarce result, and you need a health service commission controlled nationally so that it is easy and equitable distribution, so allow people access. NHIF will be reformed, as you have seen the task force, and the Kenya Medical Association is in charge of the finances at NHIF. And the group that has led today, once it does its reforms, NHIF can actually fund a large part of it. Once it's reformed, it'll be good. And therefore, let's push the government to do those things. Tax, fund. You can introduce a health tax on seen things like sugars, alcohol.
You're talking about more taxes.
Like no, a health tax, to be able to fund that, and a health service commission to be able to manage the scarce human resource.
All right, we'll be back again and we'll be discussing this a little bit more, but thank you both very much for joining us this evening and of course putting more insights on what it is that we feel we should do as a country to try and ensure we achieve universal healthcare and affordable healthcare.
Thank you for having us.
Well, we have been talking to Dr. Musuva, who is the Chief Operations Officer at Population Services Kenya, as well as Dr. Simon Kigondo, who is the Secretary General at the Kenya Medical Association. It's time for us to put a cap on your health, but up next is business news, so don't go too far.